Okay, it looks like we're slowing down a little bit and we're a couple minutes after, so we can go ahead and get started. So welcome everybody, and a special welcome to our guest today, Dr. Wendy Barrington. I'm going to take a minute to introduce her, and I just want to remind everybody that we're going to do something similar where as you think of questions, we'll put them in the Q&A and we'll manage that at the end. So let me tell you about Dr. Barrington. She received her MPH in epidemiology from the University of New Mexico and her PhD in epidemiology from the University of Washington. Currently, she is an associate professor in the UW School of Nursing, and she also holds adjunct appointments in the Department of Epidemiology and the Department of Health Services, also here at UW. Finally, she is also an affiliate investigator at the Fred Hutchinson Cancer Research Center. Dr. Barrington has an impressive track record of research utilizing community-based participatory research principles. Her work seeks to engage marginalized communities and health systems with the goal of transforming policy, practices, and norms as a way of ultimately reducing race-based disparities in health services outcomes. Her work in part has focused on disparities in cancer screening. The title of her talk today is Systemic Racism, Social Determinants of Health and Cancer. So thank you so much, and I'll let you go ahead.
Thank you so much. It is a pleasure and honor to be with you here today. We are at a unique and pivotal social moment where the nation is awakening to the very real and very pernicious ways in which social and physical environments threaten the lives of Black, Indigenous, and people of color. I'm going to take this opportunity to center our discussion on Black lives in the context of cancer prevention and control. And the goal of my talk is to invite you on a path of reconciliation and repair. And as part of this journey, I will be naming and describing some truths that may be hard to hear. And I ask that you hold any feelings of discomfort, you place them in a box, and you set that box aside for you to examine later, and then come and engage with me in examination about our role in our current systems to identify opportunities for change. Before I begin, I would like to respectfully acknowledge that the University of Washington was built on the traditional land of the Coast Salish peoples, land which touches the shared waters of all tribes and bands within the Duwamish, Suquamish, Tulalip, and Muckleshoot nations, and pay our respects to elders both past and present. Through this acknowledgement, I make explicit that I do this work while positioned both institutionally and personally on land that was essentially stolen, that I have and continue to benefit from the colonization of Indigenous lands and peoples. I've recently been introduced to efforts for local reparations for these historic acts. The first link collects contributions in the form of rent from those who live and work in Seattle to the Duwamish tribe, who, despite signing away 54,000 acres to the U.S. government in 1855, has failed to be justly compensated for their land, resources, and livelihood, and remain unrecognized by federal, state, and local governments. I invite you to explore the second link, which allows you to type in any address in the United States and find out what tribal lands that point occupies, to reflect on contributions to reconciliation and repair in those specific contexts. So why do we do this? And really, it's central to the topic that I'm going to be talking to you about today, in that the formation of the United States occurred as a direct result of traumatic insults to Indigenous and Black peoples, and these historic acts have not been undone, and they continue to shape the lives and the health of Black and Indigenous people as well as people of color. And so we come together in this space in the spirit of reconciliation and repair, and really to examine what that might look like, and hopefully that will inform and inspire and activate you to take action outside of the walls of this virtual space. To effectively partner in this work, we must have a common understanding of the problem. Today, I will provide a definition of racism, which I have found to be very helpful, and describe how it functions to systematically pattern exposure to social and physical environments. And I'll use cancer as a case study to examine how racism and the role of environments produce and perpetuate race-based disparities, and actually demonstrate similar patterns with respect to COVID-19. And finally, I'll discuss implications and opportunities for research and practice. I want to ground us in the understanding that health outcomes are underpinned by factors, including the social determinants of health, as well as more individual level physiologic and behavioral factors. And the values and assumptions and the beliefs that are kind of, bathing this iceberg, if you will, can represent social norms, which also affects the integrity of the iceberg. And the reason why I like this image is because health is just the tip of the iceberg, and along with the individual and environmental factors, forms a cohesive whole. It is one, and it exists within the glacial waters. This is congruent with a holistic approach for understanding health. And I'd also like to share my perspective as an epidemiologist and invite you to see that these factors are constantly interacting, such that what is described sums much more to a single whole. Given that the environment is constantly interacting with the individual, we must understand how individuals are distributed into environments. In essence, environments are shaped by the social determinants of health. The systematic exposure of certain groups to certain detrimental social determinants of health is determined by the social determinants of equity. And these are systems of power that allocate resources and opportunities. Systemic or institutionalized racism can be thought of as a social determinant of equity. And it is now well established, race is a social construct and functions as a proxy for differences in exposure to social determinants of health, not inherent biologic susceptibility. So if race is a social construct, what were the social events leading up to its creation? To understand this, we must revisit history and critically interrogate and name events, their purpose, and their impact. We start with the examination of how Western Europeans began to consolidate resources and create ideologies to support that effort, specifically colonization and capitalism as means of acquiring land and resources. These groups wielded genocide, enslavement, and assimilation to sustain and perpetuate these ideologies. It was imperative, therefore, to identify a social hierarchy to justify who would be the agents of these ideologies and who would be the targets. The concept of race was created to visibly identify agents and targets. However, by understanding the agents as Western European or white men and their socialization at that time, we began to understand the underpinnings of white supremacy culture and how it structures not only racism, but other systems of oppression, including sexism, heterosexism, and ableism. Now, I'm neither a historian nor a sociologist, so I'm not an expert in these phenomena. And yet I still need to have a working understanding of these concepts to understand not only my own work as an epidemiologist, but my existence in society. I posit that we all need to exercise this examination of positionality within each of our respective disciplines. As a health sciences researcher, this is imperative because of the role research played in providing quote unquote evidence in support of the concept of race and therefore racism. Clearly and understandably, there is a chasm of mistrust between communities of color and researchers. By not confronting history, however, one has no true appreciation for the reasons why. This level of awareness is first needed to establish the foundation for action. Now, to help understand racism as a system, I'm going to draw upon a framework developed by Dr. Kamara Jones, the Evelyn Green Davis Fellow at the Radcliffe Institute for Advancement Studies at Harvard University, Adjunct Associate Professor at the Morehouse School of Medicine, and the 144th President of the American Public Health Association. So in her framework, she describes and conceptualizes racism as operating on three different levels: institutionalized, personally mediated, and internalized. Institutionalized racism is systemic or structural, manifesting as practices, policies, and norms that advantage one group over another, and that results in the unequal distribution of resources, opportunities, and power. Personally mediated racism is relational and is defined as prejudice and discrimination from a position of power or privilege, and is usually people's default definition of racism. Internalized racism is personal and is defined as the acceptance of negative messages promoted by those in power, by members of marginalized groups. And it has also been defined as the conscious or unconscious acceptance of a racial hierarchy in which whites are consistently ranked above people of color. And so you can tell by that last definition that essentially all of us as actors within our society can be thought of as having some form of internalized racism. However, for my talk, I'm going to focus on systemic or institutionalized racism in the form of structural barriers. Anti-racist action at this level is imperative, for it will ameliorate other forms of racism. Today, I'm going to share examples of how racism has shaped Seattle and weave in my own as well as others' research at the national level to explore its impact on cancer outcomes. And coincidentally, cancer is the leading cause of death in Seattle-King County, as well as the outcome with the most marked Black-white disparity. Often when discussing racism, we like to discount what has happened in the past because it's just that, in the past. However, I challenge us all to dig deeper to understand that if repair has not been justly done, then the legacy of the racist acts live on. Seattle, despite its progressive identity, is steeped in systemic racism. We have a history of racial restrictive covenants, also known as redlining, where discriminatory land development and mortgage lending practices resulted in the segregation of people of color. When looking at property deeds to this day, you can still see these covenants attached unless the current or previous owner has actually had them removed. There have never been any programs or incentives to encourage the redistribution of property ownership in Seattle, and I would argue elsewhere. Furthermore, a recent study found evidence of discrimination in the treatment of prospective renters on the basis of race. So although redlining is in the past, its impact has actually never been undone, and the segregation of Black and other people of color, as indicated by the darker colors on the map, remains in Seattle-King County. And you can see here 1950 versus 2010. Given the pervasiveness of systemic racism in structuring other resources and opportunities beyond housing, we can understand how the geographic distribution of income overlays the previous map. Furthermore, we can see how disparities in income are sharpening over time as more red areas indicating the lowest income category are depicted in the most recent map. Finally, we can see the geographic distribution of lack of access to cancer screening is essentially congruent with the previous maps, where screening is an evidence-based intervention that reduces the risk of death from breast, cervical, and colorectal cancers. So now we understand how individuals have been segregated into environments and how that segregation has continued across generations. We also understand how these segregated communities are also more likely to have fewer economic resources. But yet, what are additional barriers that are in the environment? To help answer the question from my local context here in Seattle, while also seeking to generalize to the US, I initiated a national study of patient navigators. This study not only assessed navigator-reported patient barriers on their caseload, but also assessed navigation activities delivered by the navigators to address those barriers. However, given my limited amount of time today, I'm going to share my results with you about the former. The importance of this study is that it was conducted within the context of two large federal screening programs, the National Breast and Cervical Cancer Early Detection Program and the Colorectal Cancer and Control Program. Both of these are administered by the Centers for Disease Control and Prevention. I would also like to acknowledge that this work was made possible by my participation in the Cancer Prevention and Control Research Network, which is co-funded by the CDC and the National Cancer Institute. For this study, we were able to identify over 1,000 patient navigators to invite to complete an online survey. And among those invited, we received responses from 437 navigators across all 50 states, 2 US territories, and 8 tribal entities. Recognizing that patient navigators have numerous job titles, we defined the role as someone who helps people complete cancer screening. Pretty simple. Those who identified with this definition completed the survey. We asked these individuals about their background in education and further categorized those as healthcare practitioners, such as nurses, if they had formal clinical training, and health professionals, such as community health workers, if they did not have that formal clinical training. And please know that my naming of these categories was intentional. You know, there are tremendous power asymmetries or power hierarchies within healthcare, and wanting to recognize the efforts and contributions of those who do not have clinical training and not referring to them as being lay, quote unquote. So most of the respondents provided patient navigation for breast and cervical cancer screening. We collapsed these two cancers together, as over 90% of those who navigated for breast cancer also navigated for cervical cancer and vice versa. And most patient navigators had clinical training, although a significant proportion did not. Finally, patient navigators were diverse in terms of race, ethnicity, and were predominantly women who spoke English. Now I'm going to move into discussing the patient-related barriers that we elucidated in this study. Of the 12 psychosocial barriers assessed among patient navigators, 5 were highly reported, and this is an arbitrary categorization on my part, essentially putting them into quartiles. So I'm counting those as being highly reported if 75% or more of the sample of PNs endorsed that particular barrier. Specifically, highly reported psychosocial barriers included lack of knowledge about cancer, a lack of motivation to get screened, a lack of knowledge or fears about cancer screening procedures, or a lack of knowledge about the benefit of screening. Only 2 psychosocial barriers, lack of family support to receive screening and community beliefs about healthcare, were reported by less than 25% of patient navigators. And they're actually not here on the screen, but the reason why I'm calling them out is because often these barriers are seen as these are seen as barriers, whereas what we may actually need to think about them more in terms of leveraging families and communities as partners to promote cancer screening. Of the 11 structural barriers assessed among patient navigators, 2 were highly reported, specifically lack of health insurance or concerns about cost, as well as lack of transportation. I'm also showing you what I'm categorizing as moderately reported barriers, which included difficulty scheduling appointments, language barriers, and clinic hours of operation. Now, the survey results highlight these main structural barriers. However, the survey did not directly assess whether discrimination based on race was a reported barrier, and perhaps it should have. In follow-up interviews with patient navigators, additional structural barriers emerged, including lack of representation in the healthcare workforce, lack of representation in messaging about cancer screening, and lack of representation in scientific evidence underpinning screening and clinical care guidelines. So you can see how these last structural barriers suggest the presence of systemic or institutionalized racism in healthcare access and screening. And I'd like to highlight that the last bullet, as an environmental consideration, is true not only in the context of cancer care, but likely healthcare in general. So here are the screening guidelines developed by the U.S. Preventative Services Task Force for breast, cervical, and colorectal cancers. Of note, women are recommended to receive a mammogram every 2 years starting at age 50, while adults are recommended to undergo colorectal cancer screening starting at age 50, and recognizing that this actually may be in the process of being changed down to 45 years. And that's a good thing, because it's well established that we lack representation in clinical trials, a gold standard form of inquiry upon which clinical care guidelines are based. And so that's where the age ranges, those age eligibility are coming from. Furthermore, the USPSTF actually acknowledges this lack of representation and the evidence supporting their breast cancer screening recommendation. And so this may be a particular concern, given that evidence suggests that Blacks are diagnosed at some cancers, including breast and colon cancer among females, at younger age compared to whites. And yet, even if cancer screening was equitably delivered, cancer treatment is not. Numerous studies have documented disparities in the receipt of guideline concordant cancer treatment, where Black men and women are less likely to receive appropriate treatment compared to their white counterparts. Finally, I'd like to acknowledge that the chronic stress of racism itself has been implicated in cancer pathology. Specifically, studies have shown that chronic stress has been associated with 7 of the 10 hallmarks of cancer identified by Hanahan and Weinberg, the definitive experts on cancer biology, which have ultimately been related to cancer incidence and progression, as well as the effectiveness of oncologic treatment. And now we revisit the maps again in light of COVID-19, and we see the same patterns emerging with respect to higher numbers of confirmed cases overlaying the same patterns that I've been describing with respect to cancer. And specifically how that is structuring racial disparities as well. And here we can see how Native Hawaiian and Pacific Islanders have almost 5 times the rate of COVID compared to their white counterparts. Hispanic Latinos about over 4.5 times higher, Blacks 3 times higher, and American Indians, Alaska Natives almost twice as high. However, we have to recognize that these numbers are small, and so these estimates may actually be underestimates. So where do we go from here? And why am I describing the impact of racism on health to such an interdisciplinary audience? And what about other oppressions or isms? Because of the very nature and pervasiveness of white supremacy culture, Walsdorf and colleagues succinctly state, there exists a cultural thread that sustains all forms of oppression and domination, and that these oppressions are inextricably tied. We as actors in various systems must commit to action that is congruent with the tenets of social justice, notably the changing of social norms and institutions to promote equitable relationships among all actors in the various systems. And I would argue we are all actors in every system. Yet it is more than just how we treat one another, while this of course is very important. However, having this as the target of change relegates injustice to a personal or individual level act. In the health sciences, we describe the need to identify the root cause. Invoking Dr. Jones's description of the levels of racism, we need to recognize and prioritize change to mechanisms that perpetuate imbalances in the distribution of wealth, resources, and access. This is a systemic or institutional level endeavor. And so I'm sure many of you have seen this, this image in terms of, differentiating between equality and equity. And really, I really like this, and I'm going to actually add a little bit more to it as I look at it. So here we see equality, how we're having differences, and how those differences either provide the opportunity to reach the apple or they don't, and how all of them, if given equal resources in their aim to try and reach that apple, does not necessarily, get the outcome that is desired, versus an equity approach where, resource allocation is differential and it is allocated so that everyone is able to achieve that outcome. And then, I kind of offer even I've been thinking about liberating structures, and how even thinking in terms of how can we promote systems so that perhaps it's not that you're trying to reach up to the tree, but the tree is actually reaching down to you where you're at. So I like to kind of invoke two prominent social epidemiologists in really kind of providing some theory to help us understand what are potential points of action. And this is Bruce Link and Joe Phelan in the fundamental cause theory, in recognizing that most health disparities are due to inequities in access to health information and technology. And so, that begs the question, and kind of speaking to what I brought up earlier in terms of, what are the recommendations that are coming out, and are those recommendations truly meeting the needs of the population? We need to start asking ourselves some more deep questions. And I'm going to kind of introduce, and this is probably not new to you all, but it really is a framework that I find is helpful for being able to ask those questions, both in the context of research, in the context of practice, in the context of just being. And that is cultural humility. So this kind of approach or philosophy that really facilitates understanding and the respectfulness of others in that understanding. What I like to say, a cultural standpoint is belonging to a certain group imparts advantages or disadvantages, so that's inherent in this framework. From a personal standpoint, how I think of it is, what I think it's like for others is different from what it really is like for others. And so for me to always keep that in my sight in my quest for understanding. The other thing about cultural humility, I'm going to describe the tenets of it, is that it really will help you begin to interrogate how you are asking questions, what measures you are choosing to select, what approaches you are choosing with respect to investigating your line of inquiry, as well as your interpretation and dissemination of and value of whatever knowledge that you are a part of generating. And there are really three tenets of cultural humility, and I'm just going to describe them to you briefly. And the reason why I like this framework is because it attends to not only individual level work that we can do, but also systemic and institutional level changes that we can start thinking about and acting on. So the first tenet is this idea of lifelong learning and critical self-reflection, recognizing and honoring diversity, being open to understanding and acknowledging their own lack of experience and perhaps one's own conceptualization as not being entirely correct or possibly being limited, and wanting to seek additional information to expand that understanding. The second tenet really is recognizing and challenging power imbalances for respectful partnerships. And this can be done in numerous different ways, whether it's kind of community-based participatory research practices or working shoulder to shoulder to identify priorities and recommendations for change. And I would add to that, in that endeavor, recognizing positionality, not just of yourself, but also as your institution in relation to who it is that you're working with in order to cede privilege and prioritize the needs of those who have been marginalized. And then the third tenet, really this idea of institutional accountability. So actually making changes to policies and practices and norms to facilitate that work. So, again, thinking in terms of what is the impact? What is my impact both as an individual researcher, and then also what is the impact of my discipline? What is the impact of my institution with respect to the groups of people or populations that I'm studying? So how do your findings contribute to perceptions of specific racial groups, whether that be, kind of this support or refutation of biologic mechanisms linking race to outcomes, behaviors to outcomes? Are we unintentionally perpetuating negative stereotypes? Does focusing on health disparities and inherently a deficits model, does that contribute to inaction or contribute to actions, or maybe does that preclude actions that could be possible? And then how do community groups feel about this? And then what is current sociopolitical climate? Because now more than ever, that's such an important thing to wrap into how we are thinking and communicating about knowledge and what we are understanding. With respect to practice, I believe this calls for really mobilizing us to diagnose and treat systemic and institutionalized racism through interrogating in where policies, practices, and norms, how they are impacting individuals or populations, and if there are differential impacts, then attending to that and making changes so that you can actually reduce that mechanism, and then also needing to attend to that in terms of harming whatever detrimental or negative consequence had occurred, whether it was intentional or unintentional. So I highlight the leadership of Patty Hayes, the Director of Public Health, Seattle-King County, the only nurse currently leading a major metropolitan public health department. In partnership with the county executive, Ms. Hayes is explicitly acknowledging the complicity of government in systemic racism, pledging to disrupt racist mechanisms, and partnering with communities to shift budgetary priorities away from policing and towards the community health of Black, Indigenous, and communities of color. In my own research and practice, I'm partnering with the Washington Department of Health and nurses and clinic staff within federally qualified health centers to apply anti-racist strategies in the implementation of evidence-based interventions. And then also working in partnership with the Washington Center for Nursing and my BSN honors students to identify how to better assess and address patient social needs at the point of care, and really centering the voices of nurses of color in that endeavor. And then really I've started to ask these questions in my own research. How does my data collection potentially align or contribute to racist or hegemonic ideas, methods, or approaches? How does my dissemination incorporate ways of thinking or doing that is grounded in the experiences or priorities of oppressed, marginalized, or excluded peoples? And then finally, what is the impact of my research on these populations? So finally, I'd just like to close with the importance of community partnerships that preference the priorities and leadership of Black, Indigenous, and communities of color. Truly, it's been working shoulder to shoulder and sharing power in deciding how questions are asked, what methods are selected, and how findings are interpreted and disseminated. That has been transformational to me as a researcher, because only through trust building, reconciliation, and repair can we hope to truly promote health. So thank you so much. I look forward to further conversation during the Q&A session. And should I stop screen sharing? Would that kind of facilitate? Let me know what to do.
It might, yeah.
Yeah, so please, thank you so much, Dr. Barrington. That was very insightful and eye-opening to kind of think through a different lens, I think, for all of us, and kind of rethinking our own research. So please put your questions in the Q&A and I can unmute you so we can have more of a conversation.
I see a note from Fabrizio saying he's on the curriculum committee at UW School of Nursing. I don't know if that's an exclamation or Anisha Srinivasan has her hand up. Go ahead, Anisha.
Hi, can you all?
Hi there.
Hi, thanks, Dr. Barrington, for that talk. I'm a pediatrician. I'm just starting on my path of like my research journey, and you've obviously been doing health equity research for a long time. And I wonder if you could speak to doing health equity research. You're constantly coming across painful realities of systemic racism, and it's in many different levels. How do you deal with that, like personally? And it's okay, it's totally fine to not answer that question, but I find that in myself too, like how do I deal with this painful reality and keep moving forward?
I think that's a great question. And I think, we talk about the idea of self-care and really fostering and resting and rejuvenating oneself to be able to continue to engage in this journey. And I recognize that looks a lot of different ways for a lot of different people. And I recognize also that it's not necessarily valued within the academy to really talk about that, let alone practice that. And so thank you for your question, because I think that's a really, really great point. For me, I definitely have my support network. I have what I call my group of accomplices, if you will, who, are able to strategize or be sounding boards or just be supporters and kind of hype me up, if you will, in terms of, I guess, listening and understanding and being there in support. I think that's so incredibly necessary. And, that support system can stretch across disciplines. It's definitely not just completely within my field. I have accomplices and co-confidants across the university, across different networks. And that has really got me through in terms of, continuing to engage in the work.
Thank you. Thanks so much.
Mm-hmm.
Wendy, there are a few Q&As and you could read out loud or.
Yeah, I can see them. So the first question was about sharing my slides, and I'd be happy, I'll share a PDF of my slides. Another question was kind of elaborating more on unintentionally contributing to inaction by focusing on disparities. And, I've been thinking about that, and it's interesting because, in this talk, I've called out white supremacy culture, and in other venues, we've kind of talked about what are the behaviors that are kind of manifest in that. And I think part of that is this kind of framing of things in the negative, or, in terms of these comparisons, and usually those comparisons are to whiteness. And then if you're finding yourself, or if you're finding that the experience of populations are worse, than the experience of being white, then that is seen as a usually seen as an individual kind of fault, that it's not as a result of kind of systems, that it's really choices, and it's really kind of individualized. And then I think that's what kind of contributes to inaction, because then it's kind of easy to hear this discourse of, well, I mean, we even heard it in terms of, broader kind of federal people in the administration blaming populations for the experience of poverty, and equating that to not having motivation or a desire to kind of step out of that experience. And so therefore it's easy to say, okay, well, it's their fault. It has nothing to do with me. So I think that's kind of what I'm really concerned about and mindful of, and recognizing that, medicine, nursing, public health, a lot of the health sciences disciplines has really been oriented around finding fault or finding problems or finding something bad, if you will. And all of that is in relation to what is considered normal or normative or good. And needing to really kind of be very explicitly aware and interrogate what the implications of that potentially are. Whether, a lot of this stuff I think is kind of can manifest in terms of implicit bias, which we all know kind of influences how we understand things and how we choose to act or not act. And so I think that's kind of my response to that question. Sorry, it was a little long. Another question was the process for collaborating with community partners, and what does shared decision making look like? And that's a great question as well, because I think it's a dance. It totally depends on who you are and kind of what you are bringing to the table in terms of, your resources, your expertise. But it also depends on the community partners and on their side, what they're bringing to the table as well. And so it's really kind of, for me, I think of it as a process of negotiating, what is our shared vision? What is our shared value? And what do we bring to the table in order to kind of move us towards that? And what do we need to bring to the table in order for us to be more effective? So it's almost more like this process of valuing contributions, identifying how those contributions can serve this kind of common goal, and then kind of negotiating what that's going to look like. And it's different depending on what you're working on and who you are. But that's been my experience. And then just really allowing sufficient time for that, negotiation and those relationships to be built so that you have trust and so that you have this level of authenticity and understanding in what you are working on together. Okay. I'm looking at the panel, the Q&A.
So I think I unmuted Abigail. I think she has a question if she's
Great.
going to read her
Thank
question.
Hi, thank you for this presentation. I was wondering if you had any kind of specific examples of the way that you changed how you collected data or how you reported out the results in order to kind of avoid perpetuating those biases that you spoke about.
Yeah, that's a great question. And it's actually one that I'm engaged with in discussion with a class that I'm co-instructing this quarter as well. And so I'm actually in the process with my students they've actually graduated at this point, but we're continuing to work together. I'm going to kind of reference this project to center the voices of nurses of color in trying to understand how to assess and address social determinants of health at the point of care. And, my positionality as a researcher, I come from a white community. My mom is white. My dad is Black. I'm extremely privileged to be within the academy and have a lot of privileges and power that kind of comes along with that. Working with my team of two undergraduates at the time, and how we had very frank discussions about what was our goal in terms of wanting to center the voices of these nurses, and how are we going to ensure that we were really being attentive to how our positionalities might affect that endeavor. And so we actually, and I'm an epidemiologist, I'm a quantitative person, so I'm really trying to adopt, methods that are qualitative in nature in terms of reflexivity and kind of examining how one's positionality affects how one is thinking about the question, and really being explicit about that in the write-up of the paper. So, having that be a part of the methods, and talking about anti-racist strategies that we're using as a part of our sampling, as a part of how we're even asking the question, and actually reporting on that. And then in the limitations of the paper, we're actually reporting on how, despite this intention, we recognize that we still have blind spots, and, we still have, possible biases that are coming into play here because of who we are. So, that's a concrete example, and we're kind of in the process of doing that right now. But just making things explicit, I think that's the first thing, because right now everything is so implicit and so, what they call it, the hidden curriculum. There's a lot of things that are kind of unsaid in terms of how we do business, if you will. And if we can actually start being transparent and being explicit about what we're doing and what we're thinking, and kind of how our kind of positionality may be influencing that, then I think that's the first step. I hope that answered your question. Did that answer your question?
Yes, thank you. That's really helpful.
I think Fabrizio would like to talk. He's unmuted.
Yes, hello.
Hi.
My name is Fabrizio Delgado. I'm a student of the ABSN program, and I was recently selected to the curriculum committee here. And what I've been doing is discussing with professors and committee members on the topic of changing the curriculum to be more inviting to people of color, people who are Black, Indigenous, people who are LGBTQIA, and even women, believe it or not, in nursing. And one of the topics being discussed that I brought up recently is on the topic of the term professionalism occurring in courses here at UW School of Nursing. And this topic was brought to light by the book, How to Be an Anti-Racist. You guys have probably heard of that. And in it, it's discussed the idea of civilization and society, indicating you have to fit this in our civilization, and there are terms you have to fit into society. Otherwise, you are a -1 at the very beginning. And one of the topics being discussed is there was a presentation in our IP called IPE, Interprofessional Communication, I think, IPC. And the video, it starts off with a video of 3 white men with their hairs combed to the side going, how to be professional. And throughout the video, it's only 1 minute long, but they only show 2 Black men with their hair nice and shaved. And these are cartoon characters, but regardless, and maybe 1 or 2 people of color, I'm not even sure. And that's it for diversity in the entire video. There are women, of course, but none of color or none who were Black. And it perfectly fit the topic of professionalism being this look defined by society, this attitude. And so the conversation started of changing the name in it, and they agreed that it needs to be changed and the video needs to be changed. But there are courses in the School of Nursing named Professional, and after speaking with them, they are seeing that the term needs to be changed in the courses, because one brought up a really good point. She said that there was a big, and I never thought of this, there was a big self-consciousness in nursing for a time period post, short dresses, hats, of gaining the respect of men, especially in society, and trying to fit this look. But, it's definitely past that point, or hopefully past that point. And now that there are being more men in it, there's now more people of color, more people who are Black. The term professional now isn't fighting short dresses, but it's definitely, once again, still just fitting to the look of the doctors, of not even of the doctors, of white men.
Fabrizio, this is Sarah. Just quickly, do you have a question for Wendy? And do you want her to respond?
Yeah.
We have other folks who would have questions, and I just want to make sure sorry.
No, it's okay. So my question to you is, how do you feel about those terms and certain terms being used in medicine? And are they, can you name a few that you think or that segregate people who are Black, Indigenous, people of color, LGBTQIA in medicine that should be changed?
So I think that's an interesting question because, I mean, I think what you're getting at here is that a lot of the norms related to how one behaves within these various disciplines is very structured by white supremacy. And that is an opportunity for us to begin to look at these expectations and see what is missing in terms of being, how to be, and how to know, and being able to incorporate those elements within those expectations. So we talk about the word professionalism, and I don't know necessarily, I mean, I'm just talking off the top of my head here, so I'd have to think about this a little bit more, but I don't know necessarily if it's the word itself, but it's what's associated with the word that needs to change. And, you know, that can be done through, you know, a more inclusive process in which these expectations or behaviors that are supposed to govern practice are expanded, really, that they become more inclusive, that they are incorporating and making space and honoring and valuing other ways of being and other ways of knowing. So that's how I would answer that question. Thank you for that.
I think there were a couple, Christy.
Yeah, Christy, I think, is ready, right? Christy, are you able to talk? I unmuted you.
Something's muted, but.
I can read her. So she's on the screen. I can read her question, or Wendy, you could go ahead if you see it. She says,
If you got it.
you see, so it says, as school nurses, we see health disparities caused by these inequities so often, but struggle to right them without funding or resources to do so. Any thoughts on ways to address this to help and to advocate in our systems?
Absolutely. Thank you so much for that question. And I think, you know, what you're speaking to kind of in my mind, where I immediately go is to working to actually change the structures in which we are operating to deliver that care as a first step. And so, you know, what might that look like in terms of, you know, for instance, you know, being within a hospital or being on a unit in terms of, you know, delivering care and ensuring that that care is delivered equitably. And for me, it begins by starting, you know, I'm a data person, epidemiologists, we're always kind of comparing. So, you know, what is the experience of patients that are, you know, that are undergoing this particular practice, and is it the same across different groups of people? And if it's not, then what is happening that's different? You know, because we have to be able to interrogate what is happening that is causing this difference. You know, is it that there is some level of difference with respect to the timing with which people are being interacted with? Is there some difference with respect to the relationship between the provider or the nurse and the patient in terms of establishing that communication? What is it that's different there, and what could be changed to kind of facilitate more productive communication? For instance, these are just ideas and not, you know, exhaustive rather. What are other elements that are contributing to differences in the experience of patients, and how can we actually change behaviors whether it's our own, or whether it's our unit, or whether it's our institution, how can we change policies so that these experiences are not different, so that they are more equitable. I mean, I'm talking a little bit abstractly, but I mean, I'd be happy to connect with you afterwards to kind of talk about really kind of more concrete ideas that might be more specific to your context if you want to reach out to me. But I think that's really what it boils down to, is kind of breaking things into kind of more discrete moments or opportunities, and seeing what's happening that is perpetuating some kind of a difference in that particular moment or experience, and then really kind of working together to kind of identify and co-create solutions to disrupt that difference, so that difference doesn't happen. So that's kind of a start, I guess.
So I think Angela has a question. It's in chat about training, and Angela, hopefully you can talk.
Yeah, thank you. Thanks, Wendy. My question is, I was a UW alum 10 years ago, School of Pharmacy, and I didn't get this training. And I'm, if you don't see me, I'm of Asian descent. My question is, are there training right now for current students at UW? And how do I combat or actually even train myself as anti-racist too? I think I just live in a workplace that I think people mostly prefer working with Caucasian providers, and even among Asians too, within my own race. And then when I try to resolve conflict among colleagues, when they are of different race, how do I try to actively factor that in so that I'm not biased against one person over another? Thank you.
Absolutely. So I hear a couple of questions, and I'll try and start answering the ones that are in my head, and you'll have to let me know if I miss one. So with respect to your question about the anti-racist training or the anti-racism training now, I think we are, especially because of the moment that we've been in for the last 8 months related to the continued deaths of Black people at the hands of police, as well as the COVID-19 pandemic. I feel we are at this moment where eyes are being opened in terms of the need to acknowledge and really understand racism. And so I think, because of that, there are definitely units on campus that are incorporating it within their curriculum, or at least within, orientations or discussions at meetings. So I think this is happening. I know there are also numerous anti-racist trainings that are available outside the context of the UW as well. So I think there's a lot of opportunity. And so I would also, ask if you can find like-minded individuals who are interested in understanding this and almost forming a level of not like a reading group, but the reason why I'm suggesting it is because there's this level of wanting to obtain knowledge, but then also being able to dialogue with people about it, because I think that's really important. And to be able to dialogue with people first who are in support of moving in the direction of being an anti-racist institution or society, because I think that's really important. You don't want to start dialoguing with people who are not at the same place you are, at least until you start to be able to kind of get your legs under yourself, as if you will, in terms of being conversant and understanding how to ask questions, to be able to identify how these mechanisms are occurring. And then also really understanding, and I'm still learning. I mean, like I mentioned earlier, I'm not a historian and I'm not a sociologist, and I'm beginning to start to peel back these layers of history and how this is really, to Fabrizio's point, really shaped all of our notions of what it means to be in, you know, whether it's in the professions or whether it's, you know, in society as a civilian or as a mother or whatever. All of these different roles that we have has been really structured by this notion, this ideology of white supremacy. And, you know, the efforts to undo that, I think Ibram X. Kendi has dubbed this anti-racism, or actually he's kind of the most recent scholar to be discussing this, but this idea of anti-racism has been around for a while. It's also talked about in terms of being an abolitionist. So I would suggest really kind of finding people who you would be willing to kind of learn more with, and then continuing to seek opportunities where you can actually begin to apply what you're learning in terms of, you know, if you're within an institution, to be able to have conversations and say, in my own experience, what I have found effective is, you know, we all have this ideal or this vision or this value, for instance. So let's come to the table and talk about what is happening that is not congruent with that value. And what do we need to do to change that so that we can really all be working together to achieve whatever value or mission or goal or whatever it is that you can first kind of set the stage, if you will, and invite people in that journey or process with you, with the understanding that you have that shared goal or that shared vision.
Thank you.
Yeah.
Okay, well, I want to thank you again. That was really obviously very important to people and their responses. And it sounds like there's lots of people who want to follow up with you. And we'll work on getting the slides out to everyone as well. So thank you so much, Dr. Barrington. We really appreciate it. And
Absolutely. Wonderful to be here, and thank you.
Take care, everyone.